Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Substance Use Disorders, Our Colleagues, Ourselves. And joining me today is Dr. Kelly Ramsey, Chief of Medical Services for New York State OASAS. But first, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Hi, thanks, Dean, for the introduction. So we'll go ahead and get started. I'm going to jump right in by presenting a case scenario on a physician. A 34-year-old physician, HM, is an established patient in my practice or your practice. HM presents for a follow-up visit after finishing inpatient treatment for opioid use disorder. Your patient shares that 6 weeks ago, they were approached by their medical director to discuss concerns from the clinical staff about HM's behavior, which included late arrivals to work, unexpected absences, mood swings, and weight loss. After the meeting, HM agreed to an evaluation by a physician health program, or PHP, and an opioid use disorder was diagnosed. Inpatient treatment was recommended, and HM is still on a medical leave of absence. HM is currently prescribed sertraline, or name brand Zoloft, 50 milligrams by mouth daily, and buprenorphine naloxone dual formulation, name brand Suboxone, 8/2 milligrams sublingually daily. HM's aftercare plan includes attending community recovery meetings, focusing on self-care, and spending time with their spouse and children. HM reports, quote, feeling better than I have in years, unquote, and states that they have had no cravings for opioids. The patient is attending cognitive behavioral therapy sessions for the treatment of depression and opioid use disorder and is enrolled in the New York State PHP. As an internal medicine physician, what role do I play in supporting HM's recovery from substance use disorder? A second case scenario of a nurse. Karen is a skilled emergency department nurse in a hospital that treats a large number of trauma victims. In her personal life, she is struggling with issues of grief and loneliness and feels like, quote, work is therapy because I can forget for a while, unquote. One day, she accidentally goes home with a discarded opioid. She is an expert on administering pain medications to others and has witnessed relief in her patients many times after she administers the medications. That night, she is tired and too wound up to sleep, so she thinks that there will be no harm in self-administering the morphine, quote, just this once, unquote, to provide relief and some much-needed sleep. She tells herself she will not do it again. A week later, Karen again finds herself with a narcotic in her possession, and she purposely takes it home to self-inject. Within a short period of time, she is diverting on a regular basis and realizes she will experience withdrawal unless she injects regularly. Karen finds herself working extra shifts, volunteering to medicate coworkers' patients who need pain medications, and isolating from other staff members in order to procure and use the drugs. Fellow nurses in the ED recognize that something is wrong, but knowing how highly charged the department's environment is, they assume it's, quote, just stress, unquote. Karen's supervisor, Anne, notices changes in Karen's demeanor and behavior and decides to more closely monitor her practice. Anne also looks for medication irregularities or discrepancies, record falsifications, and any patterns of complaints by patients. Following hospital procedure and investigating the situation, Anne questions Karen about her performance and behavior, initially denying that she has a problem, When confronted with evidence of her impaired practice, Karen tearfully discloses her SUD. The hospital recommends treatment, describing her options, and that she may be eligible to return to work once she successfully completes a treatment program and agrees to an employee assistance program or an alternative to discipline program with random monitoring and aftercare. Karen complies and begins recovery. So first, let's go over the learning objectives for today. Discuss vulnerabilities and risks for substance use and substance use disorder. Discuss what healthcare providers should know to take care of themselves. Discuss what healthcare providers should know to take care of their peers, and discuss what healthcare providers can do for their practice or organization. First, let's talk about vulnerabilities and risks for substance use and substance use disorder, and look at the epidemiology of substance use in healthcare providers. First, a quote. A few minutes after taking cocaine, one experiences a sudden exhilaration and feeling of lightness. One senses an increase of self-control and feels more vigorous and more capable of work. And that comes from Sigmund Freud in Über Coca from 1884. So just a reminder on the pathophysiology of substance use disorder. It involves multiple regions of the brain, and it has three main phases. The binge intoxication phase, which is centered primarily in the basal ganglia, the withdrawal negative affect phase, which is centered primarily in the extended amygdala, and the preoccupation anticipation phase, which is centered in the prefrontal cortex. To have a diagnosis of substance use disorder, you need to meet DSM-5 criteria for substance use disorder. At least 2 criteria must be met within a 12-month period. How those criteria are divided are, I think of in different categories. Physiology, which involves tolerance, using more for the same effect or having less effect with the same amount used. And withdrawal, characteristic withdrawal syndrome or similar substance taken to avoid withdrawal symptoms. The core problem of substance use disorder is the individual having a knowledge of the adverse consequences caused by their substance use, yet continued use. So in other words, a compulsion to use over which they have no control. An internal preoccupation, this includes the desire to cut down on use or unsuccessful attempts to stop using. Involvement of a lot of time spent acquiring, using, and recovering from use. Larger quantities are used over a longer period of time than intended, and having cravings or a strong desire to use. Finally, external consequences. Activities are reduced or given up because of use. Role obligations are neglected, and that can be in multiple spheres of one's life, at home, at school, at work, etc. The development of social or interpersonal problems, recurrent use in situations that are physically hazardous. The severity of a substance use disorder is determined by how many criteria for a substance use disorder are met. If 2 or 3 criteria are met, they have a mild substance use disorder. If 4 or 5 criteria are met, they have a moderate substance use disorder. And if 6 or more criteria are met, they have a severe substance use disorder. So what are some of the vulnerabilities for developing substance use disorder in the general population? The largest vulnerability is due to genetic predisposition. That represents approximately 40 to 60% of the risk. So if there's any substance use disorder, regardless of the substance in someone's family tree, that puts an individual at risk of developing substance use disorder. Having a concomitant mental health diagnosis increases one's vulnerability, particularly certain mental health diagnoses, including bipolar disorder, anxiety disorder, social anxiety, PTSD, panic disorder, major depression, ADHD, specific personality disorders such as borderline personality disorder or antisocial personality disorder, antisocial conduct disorder, which is typically diagnosed in adolescence, having a history of trauma and or abuse. So particularly common is pre-adolescent sexual trauma for females, and being a victim to violence or a witness to violence is common in both males and females. Having poor coping mechanisms, and particularly initially when first initiating substance use, utilizing it for escapism, Impulsivity plays a role that figures into the physiology that I talked about a couple slides back. So impulsivity also plays a role in certain mental health diagnoses, such as bipolar disorder and borderline personality disorder. And also when we are adolescents and our brain does not fully reach development and adulthood until approximately 25 years old. Prior to that time, we function as an adolescent brain. In other words, our prefrontal cortex isn't fully formulated. And that we can think of as the more sophisticated decision-making area of the brain that weighs consequences of actions and can plan ahead. When that part of the brain isn't well developed, it leads to increased impulsivity. So particularly in the initiation of substance use, seeking a certain sensation or novelty seeking by using substances. However, by the time someone meets criteria for a substance use disorder, generally speaking, they're not enjoying their substance use anymore. Environmental triggers and sensory cues are often triggers to use or to resume use, things such as a specific scent or a specific sight or a song that's they associate with use, etc. And then the more formal definition is a lack of homeostatic reward regulation or reward deficiency. So we tend to orient our brains toward pleasurable rewards. So when we use substances, we have surges in dopamine, which cannot be matched by normal physiological pleasures that don't include substances. So particularly when we use in adolescence, we prime the brain for early substance use to have an expectation of those elevated dopamine levels. So when we talk about substance use disorder, we also need to talk about trauma. So what is trauma? It's an exposure to an actual or threatened death, serious injury, or sexual violence in one or more of four ways: directly experiencing an event, witnessing in person that event occurring to others, learning that such an event happened to a close family member or friend, or experiencing repeated or extreme exposure to aversive details of such events, such as first responders. So similar to the changes that occur in the brain due to substance use, there are very similar changes that occur in the brain from exposure to violence and trauma. So what happens is we make both anatomical changes in the brain as well as physiological changes in the brain that affect how we then in the future react to situations that perhaps shouldn't invoke such an escalated response, but they do because of that heightened hypervigilance and response that the body has ingrained after experiencing trauma. So trauma has multiple effects on individuals. On the left-hand side is showing some of the effects from a behavioral perspective and from a physical and mental health perspective. So it can lead to lack of physical activity, smoking, and development of substance use disorders, including to illicit substances, as well as overuse of prescribed medications, as well as alcohol use disorder. It can lead to missed work. With respect to physical and mental health, it can lead to severe obesity and eating disorders, diabetes, depression, suicide attempts, sexually transmitted infections, fractures, COPD, strokes, heart disease, and cancer. Another thing, when we think about trauma, we also need to think about the intersectional identities that many of our colleagues and ourselves, as well as our patients, experience in their lives. So someone who has survived trauma may have survived trauma in multiple spheres in their lives. So for example, a person may be a person who is a part of the LGBTQ plus population, as well as being a person of color, as well as being a parent and being formerly incarcerated, or they may be undocumented or have literacy issues. So there is a well-established link between trauma and addiction, and the experience of addiction may be traumatic in and of itself, as it can put individuals in dangerous situations and affect health status. Individuals with substance use disorders often experience additional trauma to the trauma that they've experienced prior to their initiation of substance use. So what are some normal responses to prolonged stress and crises? Anxiety, worry, or fear, feeling revved up, irritability or reactiveness, hypervigilance, fatigue, exhaustion, guilt, feeling overwhelmed, problems sleeping, increased emotionality, difficulty focusing, withdrawing from family and friends, change in appetite, physical pain or discomfort, and feeling numb or detached. So this is not an all-inclusive list. There are many other responses to prolonged stress and crisis that could also be considered normal, but this gives you many examples. So when we also talk about substance use, we can't neglect to talk about stigma towards people who use drugs. So stigma does exist in the healthcare setting, and stigma includes attitudes, beliefs, behaviors, and structures at multiple levels. It could be at the individual level, the group level, organizational level, or the systemic level. And this can lead to prejudice or discrimination against people with mental health diagnoses and substance use disorders, as well as others with marginalized diagnoses such as HIV and hepatitis C. Stigma perpetuates stereotypes and assigns labels like dangerous, non-compliant, or incapable of managing treatment, or dirty, at fault, etc. Stigma can be internalized to make people feel that they are not deserving of being treated with dignity and respect. This can lead to fear, shame, and isolation, and feeling unwelcome, judged, or unworthy of seeking or receiving services. And it limits a person's ability or desire to access services. Ultimately, stigma contributes to suboptimal and sometimes traumatic healthcare experiences and health outcomes. It's important that we consider the relationship between stigma and trauma. We should realize that most people have experienced trauma. So, for example, in our colleagues, we may not know that they have experienced trauma, but we need to have that insight into understanding that many people we engage with may have experienced trauma and we're not aware of it. That may be personal trauma, or it could be generational and historical trauma. As I mentioned, people with a substance use disorder are more likely to have experienced trauma, including trauma in healthcare settings and pharmacy settings, for example. Recognize how trauma affects people. As we discussed on the previous slide, trauma impacts physical health, neurobiology, and cognitive, social, and emotional functioning. What are perceived as, quote, high-risk behaviors, unquote, can be a way of coping with trauma. So we need to consider how past histories of trauma, violence, and layers of disadvantage and stigma and racism, for example, how this may affect the way a person engages with their colleagues, with providers, and, for example, with pharmacists. And we want to commit to not repeating trauma or creating more trauma or re-traumatizing people. So very briefly, some statistics. If we look at the National Survey of Drug User Health from 2020, which is the most recent data we have, and we look at the comorbidity between substance use disorder and mental health, first we'll look on the left-hand side of this slide. On the top slide, it's showing individuals who have a substance use disorder diagnosis or any mental health diagnosis, and also where those two populations converge. So out of 35.9 million individuals who have, of those with 52.9 million adults in the United States who have any mental health diagnosis, 35.9 million of them did not also have a substance use disorder diagnosis, but 17 million of them did. With respect to the substance use disorder population, 37.9 million adults had a substance use disorder diagnosis. 20.9 million of them did not have a mental health diagnosis, and 17 million of them did have a mental health diagnosis in addition to their SUD diagnosis. So if we look down on the bottom and look at where they intersect between substance use disorder and a serious mental health diagnosis, of the 14.2 million adults with a serious mental health diagnosis, 5.7 million of them also had a substance use disorder diagnosis. Of those 37.9 million adults that had a substance use disorder, 5.7 million of them had a serious mental health diagnosis. So the way to summarize it is, based on the data on the top, you can see that among the general population who has any mental health diagnosis, it's a minority of them that also have a substance use disorder diagnosis. If you look at the population of all adults with a substance use disorder diagnosis, not quite half, but more like a third, between a third and a half of them have also a mental health diagnosis. If we look at the diagnosis at the bottom, or a serious mental health diagnosis, a much larger proportion of those with a serious mental health diagnosis also have substance use disorder, whereas of the patient population with substance use disorder, a very small minority of them also have a serious mental health diagnosis. On the right-hand side is taking that data and dividing it up by substance. And if you look here, the more significant your mental health diagnosis is, the more likely you are to be using substances. So if you have no mental health diagnosis, then you have less substance use compared to individuals who have any mental health diagnosis or a serious mental health diagnosis. So regardless of which substance we are talking about, if you have a serious mental health diagnosis, you are most likely to be using, followed by those that have any mental health diagnosis. So when we're talking about ourselves and our colleagues, so looking at healthcare providers, there are some additional vulnerabilities for developing substance use disorder in healthcare providers. They have the same vulnerabilities that were listed on the slide for the general population, but they have some unique vulnerabilities. So vulnerabilities that are unique to physicians and nurses include greater access to prescription medications than non-physicians, and the ability to write prescriptions. Obviously, that does not include nurses. They have high work stress, and a culture of medical care and behaviors modeled in physician and nursing training has been faulted for promoting attributes that can interfere with physician and nurse wellness or obtaining clinical care for oneself as a physician or nurse. So some of these characteristics are as follows. Early assumption of responsibility. This may be associated with poor communication and/or coping skills. Trained to be self-reliant and self-sufficient. This may lead to self-treatment. Confidence in understanding medications may lead to self-medication. The ability to perform under stress and despite personal difficulties is a hallmark of the profession. Physicians often have sophisticated denial with elaborate justification and rationalization, making intervention more difficult. Physicians may be better at concealing use. Professional arrogance or overconfidence can lead to difficulty taking directions or input from others. Gender may be an issue. Research studies suggest that female physicians with a substance use disorder are not referred for treatment as frequently as male physicians. Also, there's the telescoping effect in women, so quicker progression to unhealthy use and consequences due to use. Lack of training regarding substance use disorder in both physician and nurse training programs. For nurses, nursing can be a stressful occupation because of negative patient outcomes, rotating shifts, and high patient-to-nurse ratios. For nurses, they have knowledge of and easier access to medication than many other professionals because of the nature of their job. Nurses often see themselves as caregivers and not as patients needing care. They tend to self-diagnose and self-medicate, believing they need to work and that this justifies their substance use. And for nurses, perceived invulnerability. So what is the prevalence of substance use disorder among physicians? So a couple studies that we'll reference here. A 2012 study involving over 7,100 American surgeons, they had almost a 29% response rate, found that 15.4% had a score on the audit C suggesting the presence of an alcohol use disorder. A 2015 study of over 7,200 American physicians of various specialties, they had almost a 27% response rate, showed that 21.4% had a likely substance use disorder, alcohol and/or other substances, based on screening with the Audit C and the World Health Organization alcohol smoking and substance involvement screening test measures. Alcohol has been found to be the most frequently misused substance in several United States samples of physicians with substance use disorders. Prescription opioids have typically been found to be the second most frequently misused substance. Physicians have been found to have higher rates of prescription drug misuse, notably benzodiazepines and opioids, compared with the general population. Prescription drugs misused by physicians are frequently self-prescribed or otherwise obtained through the physician's professional access. How about substance of choice among physicians? So this retrospective study of physician health program records of over 3,600 physicians monitored between 1980 and 2002, they asked them what their drug of choice was. So it was alcohol among 25% of them. It was opioids among 25% of them, marijuana among 12%, cocaine among 11%, sedatives among 10%, amphetamines among 4%, inhalants among 1%, and other was 8%. And what have the trends of substance use among physicians been over time? So this is a little bit harder to tease out. Clinical experience suggests that the number of physicians assessed and treated for a substance use disorder has increased significantly in recent years. But at the same time, there's been enhanced awareness of the problem from a public awareness perspective and an increased emphasis on risk management. So more people may be filtered into substance use disorder than had been in prior years without a true increase in prevalence. So this is another study that looked at the prevalence of substance use disorders in American physicians. So this was a national study of substance use disorders in a large sample of US physicians from all specialty disciplines using the AMA physician master file. And they assessed for substance use disorders by using validated instruments. So they invited over 27,000 physicians to participate, and 26.7%, or over 7,200, completed surveys. 12.9% of them were male physicians, and 21.4% of female physicians met the diagnostic criteria that was used then, which was by the DSM-4, so for alcohol abuse or dependence, which would now be called alcohol use disorder. Misuse of prescription drugs and use of illicit drugs was what was rare in this particular survey, and factors independently associated with alcohol abuse or dependence, again, that we would call alcohol use disorder today, were age, hours worked, male gender, being married or partnered, having children, and being in any specialty other than internal medicine. Specialty choice was strongly associated with alcohol use disorder. Alcohol use disorder was associated with burnout, depression, suicidal ideation, lower quality of life, lower career satisfaction, and recent medical errors. The conclusion of the study was that what we would now call alcohol use disorder is a significant problem among American physicians. Since prognosis for recovery of physicians from substance use disorder is exceptionally high, organizational approaches for the early identification of problematic alcohol consumption in physicians, followed by their intervention and treatment where indicated, should be strongly encouraged. What about the prevalence of substance use disorder among nurses? The American Nurses Association, or the ANA, estimates that 6 to 8% of nurses have a drug or alcohol problem that impairs their practice. Others estimate that nurses misuse alcohol and other substances at the same rate as the general population, which is between 10 and 15%. This means that as many as 1 in 10 nurses may be experiencing an unidentified and untreated substance use disorder. So this was a study, again, looking at the prevalence of substance use disorder among nurses, so specifically looking at substance use in registered nurses. So the background of this study was that they they estimated that substance use in nurses was on par with that of the general population, so between 6 to 8%. So they were trying to collect information to determine that, but they found it difficult based on social desirability and fears of disclosure around personal substance use. So the aim, so this was part of a larger study surrounding nurses' self-reports of substance use. They had a participant number of over 1,400, and the purpose was to explore open-ended responses of nurses, and it was 373 participants who were invited to please add any additional comments related to substance or alcohol use that you have experienced or witnessed in registered nurses. So the method of this study was a qualitative study, employed a content analysis of 373 nurses' open-ended responses collected by an online survey. The results. The majority of nurses, 250, forwarded comments that described substance use in other nurses, while 24 comments reflected the nurse's own past or current substance use. Content analysis revealed the following 4 themes: differing social network proximity to substance use, an individual process, so vulnerability to adaptive or maladaptive coping, resulting in positive and negative outcomes, bedside system and organizational spaces and effects, and there are no substance use issues in nursing. So what were the conclusions based on this study? Although direct reports of substance use constitute approximately 1/4 of the comments forwarded, nurses reported peer struggles with substance use, including observing nurses working in patient care while impaired and the use of substances to cope with work and personal stressors. Individual factors and system-related failures appear to be contributors to substance use in nurses. So looking on the right-hand side, specifically at the themes related to substance use in nursing. So differing social network proximity to substance use. So what did that mean? Secondhand reports with select firsthand descriptions of nurses' substance use. Individual process from vulnerability to outcomes, setting nurses up to use substances by having a stressful workplace, ways used to cope with stress, and professional practice and life outcomes of substance use. Bedside system and organizational spaces and effects, places of use, including bedside impairment, effect on the unit milieu, supervisors and staff, and system failures to support nurses with substance use issues. No exposure to substance use in nursing. Nurses don't have a problem. I've never seen it before. What about substance use disorder among physicians? What do we see as far as comorbidities? The prevalence of co-occurring mental health diagnoses in physicians with a substance use disorder is high, with estimates in a wide range between 25 to 75%. A study of 99 physicians who completed a PHP diagnostic evaluation by the Florida PHP found high rates of co-occurring mental health diagnoses. 30% had major depressive disorder, 11% bipolar disorder, 7% antisocial personality disorder, 7% a generalized anxiety disorder, 5% a social phobia. And what about substance use disorder among physicians when we look at clinical specialties? So we see addiction across the spectrum of medical specialties, but it does appear that there's a higher rate among physicians in anesthesiology, emergency medicine, psychiatry, and family practice. Multiple studies suggest that pediatricians have the lowest rate of addiction. And research suggests that use of specific substance classes may vary across medical specialties. Emergency medicine residents reported higher rates of current cocaine use compared with other specialties. Rates of marijuana use were higher among physicians in emergency medicine, family practice, anesthesiology, and psychiatry. Psychiatrists have been reported to have a higher rate of benzodiazepine misuse. Female surgeons have been reported to have a higher rate of alcohol use compared with other female physicians. Anesthesiologists have been found to be more likely than other physicians to use drugs intravenously and to misuse opioids and propofol. Anesthesiologists have greater proximity and access to these medications, so that is part of the issue. There is also the possibility that people with a predisposition towards substance use are more likely to pursue anesthesiology. Excuse me. excuse me, a study of 157 physicians referred to the Virginia PHP found that 39% were referred for an uncomplicated substance use disorder, 39% for a mental health diagnosis without a substance use disorder, and 21% had a dual diagnosis of substance use disorder with a mental health diagnosis. The most prevalent comorbid disorders among physicians with a substance use disorder in this Virginia PHP were bipolar disorder in 33%, depression in 24%, antisocial personality disorder in 9%, generalized anxiety disorder in 9%. So the presence of a coexisting mental health diagnosis was associated with a higher risk of return to use of substance use disorder among the almost 300 healthcare professionals enrolled in the Washington PHP. So this study was looking at, again, clinical specialties in substance use disorder among physicians, and this looked at substance use disorder in physicians after completion of training in anesthesiologist in anesthesiology in the United States from 1977 to 2013. So the methods of this study, they looked at physicians who were completing training in anesthesiology residency programs from 1977 to 2013 and maintained at least one active medical license. This was a retrospective cohort study. There were over 44,000 participants in this study. And they found some very troubling results. So 601 physicians had evidence of a substance use disorder after completion of training, with an overall incidence of 0.75 per 1,000 physician years in men. And that number was higher than it was in women, almost double the rate. The highest incident rate occurred in 1992. The rate that year was 1.79 per 1,000 physician years. The cumulative percentage expected to develop substance use disorder within 30 years was estimated to be 1.6% of those physicians. The common substances used by 353 of the individuals for whom the information was available. Opioids were the most common at 55%, followed by alcohol, 40%, and anesthetics, hypnotics at 20%. They had a median of 11.1 years of follow-up for this group of physicians, and the cumulative proportion of survivors estimated to experience at least one return to use within that 30-year period was 38%. Of the 601 physicians with substance use disorder, 19% were dead from a substance use disorder-related cause at last follow-up. The conclusion they drew from this study was that a substantial proportion of anesthesiologists who develop substance use disorder after the completion of training die of this condition, and the risk of return to use is high in those who survive. What can we expect when we look at substance use disorder among healthcare providers? What might the clinical manifestations be? The clinical manifestations do not differ very much from the general population. However, there are some unique factors that have to do with the professions themselves. So let's go over this list. Changes in mood or affect. This could be mood swings, depression, blunted affect, irritability, appearing overwhelmed, or denial. Decreased productivity, tardiness, absenteeism, frequent breaks, missed appointments. Increased mistakes, medical errors, charting errors, forgetfulness, impaired judgment. Inconsistent hours, rounding at variable times, unexplained disappearances, taking extra shifts, especially at night. Complaints from patients, colleagues, supervisors, or lawsuits. Evidence of diversion, missing or broken vials, failure to document appropriately, extra attention to patients receiving misusable medications, inappropriate prescribing. Deterioration in appearance, looking disheveled, having poor hygiene, wearing long sleeves in hot weather. Deterioration in physical health, having flu-like symptoms, appearing oversedated, having bloodshot or watery eyes, weight loss or weight gain, and a lack of coordination or tremors. Changes in social interaction, social withdrawal, increased conflicts, excessive drinking at events, inappropriate behavior, having legal issues such as arrests or DUIs. Suicidality, overdose, suicidal ideation, suicide attempts, Suicide rates among physicians are higher than in the general population. Rates among female physicians are particularly concerning. In one meta-analysis, rates of suicide were 70% higher in age-matched males and 250 to 400% higher in age-matched females compared with the general population. What can we expect the course of substance use disorder among physicians to look like? So the course of SUD in physicians has not been found to differ very much from the course within the general population, but the length of time before recognition of an active substance use disorder in physicians may vary by the substance used. Physicians who develop substance use disorder often begin to use alcohol excessively and/or use illicit substances prior to medical school. This was some research that included a survey of over 100 healthcare professionals. 51% of that group were physicians who participated in a PHP, were found to have high rates of regular use before medical or other professional school for tobacco, 73%, alcohol, over 90%, and other substances, almost 65%. Occupational risk factors for developing a substance use disorder are evident as early as medical school, likely due to increased access and higher levels of stress. As an example, an anonymous survey study of over 4,400 United States medical students found that over 34% believed it was acceptable to self-prescribe antibiotics. Over 57% believed it was acceptable to prescribe for a spouse. Students suffering from burnout were more likely to find these prescribing behaviors acceptable and less likely to believe that they have a responsibility to report impaired colleagues. And medical students with audit C scores suggesting an alcohol use disorder, over 32% were less likely to believe they had a responsibility to report a colleague impaired by alcohol or other substances. What can we expect the course to be in substance use disorder among nurses? So prior to the 1980s, nurses were often fired by employers or disciplined by the Board of Nursing when evidence of substance use became apparent. Non-disciplinary programs offering alternative to traditional discipline are now used by a growing number of state boards of nursing. These programs provide the nurse with rapid involvement in treatment, so in a rehabilitation or treatment program, and remove the nurse from providing care until safety to practice can be established and confirmed. When treatment for nurses is individually tailored to meet their needs and an appropriate supportive monitoring system is in place, nurses can recover and return to practice safely. There's been an extensive body of scientific evidence demonstrating that approaching substance use disorders as a treatable medical condition is extremely effective for the individual using substances as well as for society. Although it's common for a nurse to deny allegations of substance use, some nurses experience relief when confronted. Most nurses will comply with the recommendation to avoid loss of licensure or any public action or discipline taken on their license. Nurses in an alternative to discipline program may be asked to refrain from practice or temporarily inactivate their license until deemed safe to practice. After a nurse successfully completes the recommended treatment and complies with the state monitoring program, nurse leaders should advocate for and support the nurse's return to work. According to the National Council of State Boards of Nursing, approximately 70% of nurses who seek treatment successfully return to practice. The nurse in a state monitoring program will have a return to work agreement, which includes approved areas of nursing, limitation of hours worked per week, restrictions on opioid handling, if any, and required direct supervision and performance reporting. The nurse returning to work will continue to have random testing while under the monitoring agreement. It's vital for the nurse supervisor to have knowledge of the nurse's enrollment in a monitoring program and information on the contents of the return to work agreement. What are some risk factors for return to use in healthcare professionals with substance use disorders? The objective of this study was to test the hypothesis that healthcare professionals with substance use disorder using a major opioid, which they defined as something like fentanyl, morphine, meperidine, as their drug of choice, is at higher risk for return to use. The design of this study was a retrospective cohort study of almost 300 healthcare professionals enrolled in the Washington State PHP, which is an independent post-treatment monitoring program, and they were followed between January 1st, 1991 and December 31st, 2001. The main outcome measure were factors associated with return to use, defined as the resumption of substance use after initial diagnosis and completion of a primary treatment for substance use disorder. What were the results? 25% of the individuals who participated in this program had at least one return to use. A family history of a substance use disorder increased the risk for return to use. The use of what they termed a major opioid increased the risk of return to use significantly in the presence of a coexisting mental health diagnosis, but not in the absence of a coexisting mental health diagnosis. The presence of all three risk factors, major opioid use, dual diagnosis, and family history, markedly increased the risk of return to use by 13 times. The risk of subsequent return to use increased if someone had one return to use. So what was the conclusion drawn here? The risk of return to use with substance use was increased in healthcare professionals who used a major opioid or had coexisting mental health diagnosis or a family history of a substance use disorder. The presence of one or more of these risk factors and a previous return to use further increase the likelihood of another return to use. And these observations should be considered in monitoring of recovery of healthcare professionals. So this was a paper that was looking at comparing initial clinical presentations, service utilization patterns, and post-treatment functioning of nurses and physicians who receive services in addiction treatment programs. This was an exploratory study that combined data that was collected through retrospective record reviews and prospective questionnaires. There were three types of dependent variables in this study: the initial clinical characteristics, the treatment utilization patterns, and post-treatment functioning. The independent variable was membership of their professional group, so whether that was a nursing professional group or a physician professional group. Time both in treatment and between discharge and follow-up were covariates. So what were the results in this study? Nurses and physicians showed comparable results in most domains. Among the differences between the two groups, a few were noteworthy. So nurses showed significantly less personality disturbance, which means personality disorder diagnosis, than physicians, although they tended to work in and live in environments with more triggers to return to use, such as having other people with a substance use issue in their work or home environment. After the index hospitalization, nurses received less primary treatment, worked longer hours, and were more symptomatic than physicians. Furthermore, nurses reported more frequent and severe work-related sanctions as a consequence of their substance use disorder. So the conclusion was, in most areas of study, nurses and physicians demonstrated comparable results. However, there were some significant differences between these groups, showing that they have unique clinical needs. So this study was looking at early career nurse reports of work-related substance use. So the aim of this study was to explore the culture of substance use among nurses in their first 5 years of practice. The methods of the study were a qualitative descriptive design using virtual focus groups in an online platform. They collected the data from February to March of 2019, so pre-pandemic, and there were a small number of participants, only 23. And this was an open-ended focus group guide on work stress and the health model. So among the results, they identified three major themes: see no evil, speak no evil, hear no evil, it's somewhere out there, and caffeine is king and alcohol is queen. So participants reported high caffeine use and moderate alcohol use to cope with shift work and work stress. There was general acceptance of marijuana use in states that legalized it. Participants were reluctant to fully describe illicit substance use on a personal or a unit level basis. However, substance use was identified as a profession-wide problem for nurses. What were the conclusions of this study? Early career nurses enrolled in the study reported that they relied on caffeine, alcohol, and other substances before, during, and after their workday. These substances are readily reported and deemed acceptable by their peers. New nurses could benefit from coping strategies that do not include substance use to manage work stress and professional challenges such as shift work. Next, I want to look at the impact of the COVID-19 pandemic on mental health and substance use, and particular impact on physicians and nurses. So first, some general data. This again comes from the National Survey on Drug User Health from the 2020 data, looking at perceived COVID-19 pandemic effect. On the left-hand side is looking at alcohol use by age. So it's a minority of people who reported that they are using more alcohol than prior to the pandemic. Most people report that they are using about the same amount of alcohol. It's similar with respect to substance use, that most people do not report that they're using more during the pandemic than they were prior. However, there is a minority of individuals that indeed do report more. Most people report that they remain the same in their substance use. How about a negative effect on emotional or mental health among adults 18 or older by past year mental health diagnosis status. So this was looking at data from the fourth quarter of 2020, and it was looking at a total, those with any mental health diagnosis, those with a serious mental health diagnosis, and those with no mental health diagnosis. So you can see among those with no mental health diagnosis, it is only a minority of people who felt like the COVID-19 pandemic had a negative effect on their emotional or mental health. However, if we look at any mental health diagnosis, we can see that actually a majority of people with any mental health diagnosis did report a negative effect on emotional or mental health due to COVID-19. If we look at individuals who have a serious or significant mental health diagnosis, then a significant majority of them experienced a negative effect on their emotional or mental health due to COVID-19. On the right-hand side is looking at the negative effect on mental health services among those 18 and older who received services. This is fourth quarter 2020 data. So this is broken up by age, 18 and older, 18 to 25, and 26 or older. So you can see that for the majority of patients in all age categories, appointments moved to telehealth from in-person. Patients in all categories experienced significant delays or cancellations in appointments. And then a smaller proportion of individuals experienced delays in getting prescriptions. And then you can see that there was also a small minority of people, about 10%, regardless of age group, who were unable to access needed care, resulting in moderate to severe impact on their mental health. I'm going to change gears and look at overdoses both before and during COVID-19. We saw a significant increase in overdose deaths, primarily due to illicitly manufactured fentanyl and its analogs during the COVID-19 pandemic. On the left-hand side here is looking at data prior to COVID-19. So it's looking at deaths in 2019, which were being driven by illicitly manufactured fentanyl and its analogs at that time as well. On the right-hand side is looking at data pre-COVID-19 and during the first 6 months of the pandemic. So it's covering the period of September 2019 to September of 2020. Despite a decrease overall in overdose deaths that occurred in 2018, unfortunately, overdose deaths started trending up again in the fall of 2019, a full 6 months before the COVID-19 pandemic forced lockdown in the United States. So as you can see here in that last row, during that time period from September 9, 2019 to September 2020, 55% of the deaths were attributable to illicitly manufactured fentanyl and its analogs, but there was also a significant increase in cocaine-related deaths by 38% and a significant increase in methamphetamine-related deaths by 46%. And then, unfortunately, we received data in May of 2022 of the provisional estimated overdose deaths through December 2021. So for the calendar year of 2021. So unfortunately, there were over 107,000 deaths during that time period due to overdose. This was an overall 15% increase in deaths compared to 2020, and about 2/3 of those deaths involved illicitly manufactured fentanyl and its analogs. And there was also a significant increase in deaths due to methamphetamine use. This is looking at the overdose data through 2021 for New York State, separated out between New York City and New York State outside of New York City. So you can see that in New York City, there was a 139% increase in overdose deaths, and in New York State outside of New York City, that increase in overdose deaths was by 60%, and that's for the time period of 2015 to 2021. We also saw an increase in alcohol-related deaths during the COVID-19 pandemic. So the number of deaths involving alcohol increased from 2019 to 2020 by 25.5%. The number of deaths with an underlying cause of alcohol-associated liver disease increased by over 22%, and the number of deaths with an underlying cause of alcohol-related mental health and other behavioral disorders increased by over 35%. Opioid overdose deaths involving alcohol as a contributing cause increased by almost 41%. And deaths in which alcohol contributed to overdoses, specifically on synthetic opioid deaths other than methadone, so fentanyl and its analogs, increased by 59%. Alcohol-related deaths accounted for 2.8% of all deaths in 2019 and 3% of all deaths in 2020. And what about mental health impacts of the COVID-19 pandemic? So we have a lot of research at this point that highlights increases in anxiety, depression, and traumatic stress, as well as stress and loneliness in the United States due to COVID-19. With respect to overall mental health, the APA did an annual survey on stress and mental health. They conducted that in August of 2020, which included over 3,400 adults and over 1,000 teens. 19% of adults described their mental health as worse in 2020 compared with 2019. With respect to stress, 78% of adult responders reported that the COVID-19 pandemic was a significant source of stress in their lives. 67% of adults reported increased stress during the pandemic. 49% of adults reported negative effects of increased stress. And this had a wide variety of effects, including increased bodily tension in 21%, being very quick to anger in 20%, unexpected mood swings in 20%, and screaming or yelling at a loved one, 19%. With respect to anxiety, studies have found that more individuals have met criteria for generalized anxiety disorder during the COVID-19 pandemic. In a survey of adults in June 2020, 26% of respondents were symptomatic for generalized anxiety disorder. This was 3 times the percentage of persons in 2019. And in the United Kingdom, over 24% of adults surveyed met criteria for generalized anxiety disorder, compared with only 5% in 2019. With respect to depression, in June of 2020, researchers found that over 24% of adult respondents were symptomatic for depression, 4 times the percentage of persons in 2019. And in another study in March to April of 2020, the prevalence of symptoms of depression increased in every severity category and more than tripled in the study population compared to before versus during the pandemic. So when we look at the impacts on mental health, there are definitely increased vulnerability for mental health symptoms, substance use, and suicidality in specific populations. I'm not going to focus on all of these populations here. They're mentioned on the slide. I'll mention briefly the categories, and then I want to focus on the healthcare workers. So youth, especially those between 18 and 24 years old, women, racial and ethnic minoritized communities, individuals with lower incomes and less money in savings, individuals who are homeless, and older adults. When we look at healthcare workers, there was increased job-related anxiety due to COVID-19. This increased from it being experienced in 1% of the population to 27%. There was increased generalized anxiety disorder at almost 16%, increased depression at 14%, and PTSD at over 23%. So we do know that another impact of the COVID-19 pandemic was on increases in substance use. There was a survey published early on in the MMWR, or the Morbidity and Mortality Weekly Report, in June of 2020. 13% of adult respondents reported that they had begun or increased substance use to cope with stress or emotions due to COVID-19. And other research has been found to have shown increases in alcohol use during the COVID-19 pandemic as well, in all subgroups, but most specifically in women. There were also changes in the type of delivery of substance use disorder treatment. There was rapid transition to telehealth, either via audio video or audio only in March of 2020, loosening of federal and state regulations to allow for expanded use of telehealth during the public health emergency. And we know that there are both benefits and drawbacks of telehealth that have been noted by providers and by patients. So, what has the impact of COVID-19 on physician burnout been globally? So, this was a study that was looking at what we knew about what factors or potential factors contributed to burnout among healthcare professionals amidst the pandemic. And this review also makes a few recommendations on how best to prepare intervention programs for physicians. In August of 2020, a systematic review was done using the Medline and Embase or Ovid database to search for papers on the impact of COVID-19 on physician burnout. So they used a variety of terms such as COVID-19, pandemic, burnout, healthcare professional, physician, et cetera. And they looked for relevant studies to include in the review. So 5 primary studies met their inclusion criteria. A further 9 studies were included, which evaluated the impact of occupational factors, gender differences, and increased workload and sleep deprivation on burnout prior to the pandemic. Additionally, 5 reviews were analyzed to support their recommendations. Results from the studies generally show that the introduction of COVID-19 has heightened existing challenges that physicians face, such as increasing workload, which is directly correlated with increased burnout. However, exposure to COVID-19 does not necessarily correlate with increased burnout, and they suggested that this is an area for more research. So what was their conclusion? There is some evidence showing techniques such as mindfulness may help relieve burnout. However, given the small number of studies focusing on physician burnout amidst a pandemic, conclusions should be taken with caution. More studies are needed. We also are going to look at the changing face of medical professionalism and the impact of COVID-19 on medical professionalism. So 2 quotes here, and these come from England, from 2 physicians in England. Morale among doctors is generally declining. A survey in the United Kingdom showed that 54% of physicians reported morale as low or very low, and burnout is rising. The estimated prevalence was between 66 and 80%. There is a crisis in staff retention in some countries, with up to 48% of doctors considering leaving the profession. The COVID-19 pandemic has changed how health professionals work, how we behave and interact with our teams and our organizations, our understandings of personal health and risk, inequalities between doctors with different risk factors, and well-being and mental health. Globally, more than 300,000 healthcare workers have been infected with COVID-19 in 79 countries, and over 7,000 have died, and many more have suffered as a result of stress, burnout, and moral injury. And those quotes are from February of 2021. This study sought to look at the impact of physicians' COVID-19 pandemic occupational experiences on mental health. They were specifically trying to determine the association between a number of negative COVID-19 occupational experiences and probable anxiety, depression, and PTSD among physicians. This was a cross-sectional examination of a longitudinal registry consisting of physician personal and occupational well-being. They used multivariable logistic regression to determine the association between negative COVID-19 experiences and outcomes. Of the 620 eligible physicians to take part in the study, approximately half were female, 49%, 71% were white, and there was a mean age of 46.5 years. A 1-point increase in negative experience score was associated with a 23% increase in probable anxiety, a 23% increase in probable depression, and a 41% increase in probable PTSD. Their conclusions: negative pandemic experiences were strongly associated with adverse mental health outcomes, while greater resilience was protective. This study sought to assess the crisis of COVID-19 impact on the next generation of physicians. This was a survey of 800 medical students. So the method of this survey, it was done at the University of Paris North, and they took a weekly official census of the involvement of over 1,200 fourth to sixth year medical students during the first lockdown in France. 6 weeks after the lockdown began on May 4th, an e-questionnaire was sent to over 2,100 second to sixth year medical students. The survey lasted 4 weeks and documented volunteering by medical students, the association between the pandemic and certainty for their profession, their choice of medical specialty, and factors that influence sadness and anxiety scores. So what were the results? 82% of the fourth to sixth year medical students volunteered to continue their internship or be reassigned to COVID-19 units. Of over 800 second to sixth year students who completed the e-questionnaire, 93% volunteered in COVID-19 units, of which half acted as nurses. This engagement reinforced the commitment of 92% of volunteers to become physicians. But at the peak of the outbreak, 17% had doubts about their ability to be physicians, while 12% reconsidered their choice of future specialty. Finally, 38% of students reported a score of 7 out of 10 or more on the sadness scale, and 43% a score of 7 out of 10 or more for anxiety. Neither study year nor service influenced sadness or anxiety scores. However, gender influenced both, with women scoring significantly higher than men. So what were their conclusions? Medical students at the University of Paris North who made an early and unconditional commitment to help hospital staff handle the pandemic constituted a powerful healthcare reserve force during the crisis. Although the vast majority remained convinced that they wanted to become physicians, the experience came at a significant psychological cost, especially for women. Alleviating this cost would improve future crisis responses. This study was looking at the prevalence of sleep disturbances among physicians and nurses facing COVID-19 patients, and it was a systematic review and meta-analysis. So this, again, was a meta-analysis looking at multiple studies. What were the results? So they wanted to look across studies and look at the prevalence of sleep disturbances in both nurses and physicians. What they found was that sleeplessness was very common in both physicians and nurses during this time period. They found in 6 studies using a sample size of over 3,700 nurses that the prevalence of sleep disturbances was almost 35%. The prevalence of sleep disturbances in physicians looked at 5 studies with a sample size of over 2,100 physicians, and they found that the prevalence of sleep disturbances in physicians was almost 42%. So what was their conclusion? Healthcare workers, as the front line of the fight against COVID-19, are more vulnerable to the harmful effects of this disease than other groups in society. Increasing workplace stress increases sleep disturbances in the medical staff, especially nurses and physicians. In other words, increased stress due to the exposure to COVID-19 increases the prevalence of sleep disturbances in nurses and physicians. So their recommendation was that policymakers work to provide solutions and interventions to decrease workplace stress and pressures on medical staff. These were 2 more studies, again, looking at mental health effects and insomnia and stress during COVID-19. So on the left-hand side, they were trying to assess psychological responses of healthcare workers and related factors during COVID-19. They looked at sociodemographic data, information on individuals' working conditions, and depression, anxiety, and stress scales. They had 442 participants. Of those, almost 65% had symptoms of depression. Over 51% had symptoms of anxiety, and over 41% had symptoms of stress. Being female, young, and single, having less work experience, and working in frontline settings were associated with higher scores, whereas having a child was associated with lower scores. Frontline workers, what they reported compacted the situation for them were increased weekly working hours, increased number of COVID-19 patients cared for, lower level of support from peers and supervisors, lower logistic support, and lower feelings of competence during COVID-19 related tasks. Their conclusion were that they identified many factors which need to be taken into consideration to protect the mental well-being of physicians while combating COVID-19. On the right-hand side, looking at insomnia and stress, this was a cross-sectional study of over 250 physicians from different medical settings. The mean age and experience of the physicians were 35 years old and 10 years in practice. The median duration of dealing with suspected or confirmed cases of COVID-19 ranged from 0 to 30 days. The average was 1 day. And then they looked at sleep scores and stress scores, and physicians with respect to sleep scored 8.4 out of 24 and 4.2 out of 10. So more than 2/3 of the physicians were sleepless, or 68.3%, and the majority had stress, 93.7%. It did not find a difference in sleep scores across specialties within the physician group. And most physicians were sleepless regardless, again, of what their specialty was. So for anesthesia and intensive care, it was almost 78%. For general physicians, it was almost 81%. OBGYNs, 80%. Many were sleepless in the morning, but more so in the evening. And those that worked nights were 100% sleepless. Those who worked variable shifts, 71% were sleepless. So again, the study confirmed that working with COVID-19 patients has a negative effect on the sleep of physicians. So continuing with the theme of impact of the COVID-19 pandemic on physicians, how has it had an effect on physicians' practices and on their patients? So 8% of physicians said their practices closed as a result of COVID-19, or approximately 16,000 practices. 4% plan to close their practices in the next 12 months. 43% of physicians reduced staff due to COVID-19. 72% of physicians experienced a reduction in income due to COVID-19. 12% of physicians, or approximately 100,000, switched to a primarily telemedicine practice as a result of COVID-19. 12% of physicians, or approximately 100,000, switched. Oh, excuse me, that was a repeat. 52% of physicians plan to increase their use of telemedicine in their practices. 72% of physicians indicated that COVID-19 will have serious consequences for patient health in their communities because many patients delayed getting care they needed during the pandemic. With respect to physician burnout, 58% of physicians often have feelings of burnout compared to 40% in 2018. 22% of physicians know a physician who has committed suicide. 13% have sought medical attention for a mental health problem caused by COVID-19's effects on their practice or employment situation. 37% of physicians would like to retire in the next year. What has the impact been like of COVID-19 on nurses? So this was a survey done by Hunter Joslin and the American Nurses Foundation with over 9,500 nurses. The question, in the past 14 days, have you experienced any of the following feelings? 75% reported feeling stressed, 68% reported feeling frustrated, 67% reported feeling exhausted, 62% reported feeling overwhelmed, 58% reported feeling anxious. To the question, in the past 14 days, have you experienced an increase in any of the following? 68 reported difficulty sleeping, 43% reported overeating, 27% reported difficulty in relationships, and 20% reported alcohol consumption increased. For trauma questions, have you had an extremely stressful, disturbing, or traumatic experience due to COVID-19? 42% reported yes. To the question, for those who have experienced a traumatic event, please indicate how much you have been bothered by the following problems in the past month. Avoided activities are situations because they reminded you of your experience. The darker the color is, the worse it is. So a significant number reported that, as well as difficulty concentrating, feeling distant or cut off, feeling irritable or having angry outbursts, feeling upset when something reminded you of your experience, or having repeated disturbing memories, thoughts, or images of your experience. How would you rate your emotional health? So since March 9, 2020, have you sought professional mental health support? 31% reported yes. For those who have selected yes, were you able to find the professional mental health support you needed? 80% said yes, but 20% said no. For activities to strengthen well-being, 65% reported spending time with friends and family, 52% reported leisure or entertainment, reading, movies, art, music, 51% reported spending time in nature or with animals, 42% reported receiving the COVID-19 vaccine, 40% reported talking with colleagues. Do you agree or disagree with the following statements? If I did the best job possible, my organization would notice. So you can see that everyone was neutral on pretty much all of these questions. So they did not feel well supported by their organization with respect to their well-being, their accomplishments, that their complaints would be heard, that their organization took pride in their work, or that the organization valued their contribution to their well-being. In the next 6 months, do you intend to leave? 21% said yes, and 29% said maybe. So again, we have a significant shortage in the nursing workforce, and we can see that about 50% are planning to leave or are considering leaving. So when asked why they were considering leaving their position, 47 reported work is negatively affecting my health and well-being. 41% reported insufficient staffing. 31% reported a lack of support from their employer during the pandemic. 25% reported inability to deliver quality of care consistently. 24% reported distrust of my employer. So significant issues that we need to improve upon. So when we look at the impact of the COVID-19 pandemic on physicians, and we look at burnout and post-traumatic stress disorder in the COVID-19 pandemic, we see that there's definitely an intersection, impact, and interventions between burnout and PTSD. So if we look at the drivers of burnout and PTSD, you can see that they're similar, but there are some differences. So with respect to burnout, there's often a lack of control over your job, excessive workload, prolonged work stress, and an imbalance between demands and the skill set. If we look at PTSD due to COVID-19, often that's due to medical illness, mass conflict and displacement, combat, and physical injury or assault. When we look at the symptoms of burnout, it can include emotional exhaustion, depersonalization, and a decreased sense of accomplishment. When we look at PTSD, we see intrusive thoughts, nightmares, or sleep disturbances, flashbacks, avoidance, and hypervigilance. When we look at the consequences of burnout, we see decreased productivity, decreased quality of patient care, decreased patient satisfaction, increased turnover, increased medical errors, increased substance use, increased depression and suicide, disrupted relationships. Some of the consequences of PTSD include anxiety, depression, somatic symptoms, substance use, suicide, and disrupted relationships. So a lot of overlap when we look at the consequences. When we look at the interventions for burnout, often these should be organizationally directed, including decrease clinical demand via schedule changes, increase teamwork, increase individualized job control, increase shared decision-making. Those that are specifically physician-directed include mindfulness and CBT. When we look at interventions for PTSD, these can include psychotherapy, such as exposure therapy, EMDR, which is eye movement desensitization and reprocessing, and CBT, or cognitive behavioral therapy, and it can include medication. So what should healthcare providers know to take care of themselves? So we already reviewed the criteria for the DSM-5 diagnosis of substance use disorder. So if you think that you may have an issue with alcohol or other substances, then you have to ask yourself the following questions. Am I spending less time on activities that were once important? Am I using alcohol or other substances more than intended? Am I having a strong desire to drink or use substances? Have I attempted unsuccessfully to stop using alcohol or other substances? Am I experiencing problems that are caused or worsened by alcohol or other substances? Am I continuing to drink or use other substances despite experiencing problems? Am I experiencing a change in tolerance? Am I using substances in potentially dangerous situations, such as while driving a vehicle? Am I failing to fulfill obligations at home, work, or school? Am I experiencing withdrawal symptoms when substance use is cut down or stopped? And am I spending a great deal of time getting, using, or recovering from the effects of substances? What should healthcare providers know to take care of their peers? So first, a quote. The onus cannot fall only on impaired physicians to heal themselves. Physician colleagues and supervisors need to reach out to them. This comes from the WELL toolkit that was released in 2020, and the website to access it is there. Let's go back to that initial case scenario of the physician that I shared. So as we have seen throughout this presentation, physicians are not impervious to substance use disorders. Studies have suggested that the prevalence of substance use disorder among physicians is about 10 to 15%, or very similar to the rate among the general population. Alcohol use disorder is the most common type of substance use disorder in physicians, and a national survey of US physicians for all specialties found that female physicians reported alcohol use disorder at a higher rate than male physicians. In addition, some medical specialists, such as anesthesiologists, may experience higher rates of a non-alcohol related substance use disorder because of occupational exposure and access to medications in the workplace. There are limited published data on the topic, and reporting bias is likely because the sensitivity around an SUD diagnosis for practicing physicians. Therefore, the true prevalence of SUD among physicians is unknown. Physicians experience several risk factors for the development of substance use disorder, including high levels of work-related stress, exposure to illness, trauma, and death, and untreated depression or other mental health diagnoses. With evidence-based treatment and peer and professional support, physicians who have a substance use disorder can recover their health and continue meaningful careers in medicine. So when we think about substance use disorder in physicians, we need to think about identification and engagement. So first of all, there's recognition. So colleagues play a primary role in identification of physicians with an active substance use disorder. Reports to physician health programs come from many sources, including patients, families, hospital staff, coworkers, peers, and the legal system. Colleagues who suspect that a physician is misusing substances should not attempt to establish or confirm a diagnosis, which should be left to a professional evaluator. It is important to note and document the behaviors and events that indicate possible substance misuse. What are the responsibilities of colleagues? Reporting a colleague or friend with a suspected SUD to a PHP or a medical board can be difficult. Research suggests that many physicians are reluctant to report a colleague, even one they suspect is impaired or incompetent. One may wish to avoid confrontation or may fear that he or she is harming the physician's career or reputation. This conspiracy of silence has the potential to cause harm by allowing a physician to continue practicing while impaired. Physicians share a duty to patients, their affected colleague or friend, and their profession to address promptly substance misuse to a fellow physician. Specific potential ramifications of not intervening include putting the physician's patients at risk of harm, subjecting themselves to potential professional or legal sanctions, denying the physician an opportunity for treatment, and the long-term impact of the SUD on the physician's family and career. It's important to understand the reporting requirements in New York State for potentially impaired physicians. So who files complaints? I've added 2 websites there where you can go for more information, but all licensed health professionals, including physicians, physician assistants, and specialist assistants, are required by state law to report colleagues whom they suspect may be guilty of misconduct. Failure to report suspected instances of misconduct is in itself misconduct. If you believe a colleague's actions may constitute misconduct, you can contact the OPMC. Practitioners suspected of having problems with alcohol, substances, or mental health, but whose ability to practice is not impaired, may be reported to the Committee on Physicians' Health, or the CHP, of the Medical Society of the State of New York, or MSNY. All calls are confidential. CHP identifies, refers to treatment, and monitors impaired physicians. The program is voluntary and participation is confidential. The names of physicians participating in the program are not shared with OPMC, which is the Office of Professional Medical Conduct, without a participant's approval unless there is a failure to comply with treatment recommendations. If you believe, however, that a colleague's medical performance may be impaired, you must contact OPMC. The law does not exempt physicians from their duty to report colleagues practicing with a suspected impairment to OPMC because they have reported to CHP. However, this requirement does not apply if compliance would violate a physician-patient relationship. So what does the law state in New York? And I've put the link there to Article 131A, which has the definitions of professional misconduct applicable to physicians, physician's assistants, and specialist assistants. So some of the excerpts from that article include practicing the profession while impaired by alcohol, drugs, physical disability, or mental disability. And again, pardon the stigmatizing language that exists in the article, but I'm going to read what the article actually says. Being a habitual abuser of alcohol or being dependent on or a habitual user of narcotics, barbiturates, amphetamines, hallucinogens, or other drugs having similar effects, except for a licensee who is maintained on an approved therapeutic regimen, which does not impair the ability to practice, or having a psychiatric condition which impairs the licensee's ability to practice. On this page, I have the how to report potentially impaired physicians in New York State. So this is how to report to the Committee for Physicians' Health. So as I mentioned, anyone can make that referral to CPH. Most referrals, 75% of them, in fact, come from colleagues or physicians seeking help for themselves, nurses, other healthcare professionals, workers, friends, and family members concerned enough to help also initiate referrals. As I mentioned, that is confidential reporting. Once the referral is made, staff from CHP investigate and gather the information and then interview the physician who was, or physician, et cetera, assistant, et cetera, who was reported. So what they say on their website is denial is a significant part of the disease and often the initial response. However, when approached by concerned and caring colleagues, most physicians will candidly admit a need for help and will agree to participate in the program. So CPH does not refer physicians to the New York State Department of Health's Office of Professional Medical Conduct, as I mentioned on the previous slide, as long as the physician agrees to participate, stays with the program, is helped by treatment, and does not present an imminent danger to the public. The New York State Department of Health, Office of Professional Medical Conduct, or OPMC. I have the links here that you can follow up with. If you wish to file a complaint, I put the link there. Before printing and filling out a complaint, you should read that form. And the OPMC reviews all complaints of professional medical conduct against licensed physicians, physician assistants, and specialist assistants, including complaints of sexual harassment and assault. What about for nurses? What are your responsibilities? So as we've seen, the prevalence of substance use among nurses is also similar as it is in the general population. So about 10 to 15% of the nursing population will have substance use disorder. So it's important to also identify nurses who have substance use and are potentially impaired by their substance use. So it's important that supervisors be educated and supportive, and they are able to identify colleagues among their nurses that have substance use and substance use disorders so they can help them access help promptly. So if sometimes it's difficult for individuals to recognize in the colleagues the warning signs of a substance use disorder. So you may misread cues and often look for other explanations for behaviors. So unfortunately, that's why many nurses with substance use disorder are unidentified, unreported, untreated, and may continue to practice where they may have impairment that could potentially endanger the lives of patients. As a nursing leader, you have an important responsibility to keep patients and staff safe while maintaining high standards of nursing care on your unit. Part of the responsibility includes open communication with staff and administration of the facility. Substance use disorder is rarely discussed on nursing units, and affected nurses are afraid of being caught and what the repercussions on their career may be. Other nurses on the unit may be unaware of the signs and symptoms of a substance use disorder or may not be certain what to do or what their responsibilities are. They may not want to jeopardize the career of their colleagues. So it is important as the nursing supervisor or leader to educate your staff, dispel myths, and take action when needed. So what are some of the activities that a nurse manager should engage in with the staff on their unit? Educating staff, holding an in-service education on substance use disorder, disseminating resources, and informing staff of the manager's responsibility to identify nurses with signs of substance use disorder and the importance of linking them with help. Dispel myths and misconceptions around substance use disorder. Ensure that the staff know how to recognize the signs of substance use disorder in a colleague. Maintain a confidential open door policy. Inform staff of the Nurse Practice Act and regulations regarding substance use disorder, and understand that a nurse with substance use disorder needs support and treatment, not judgment, negativity, or hostility from colleagues. Have a policy in place on the unit that outlines substance use disorder, as well as a procedure to follow should the manager or staff become aware of a nurse that may be impaired by substance use disorder. The policy should include the following: the process to start a suspected impairment, the process to report suspected impairment, the maintenance of confidentiality, with the exception of mandatory reporting requirements to state and federal agencies, an auditing process of medication records, and fitness for duty evaluations. The ANA did release a code of ethics for nurses with interpretive statements, and this was looking at patient protection and impaired practice. It reiterates some of the points that I made on the previous slide. So how do you report potentially impaired nurses in New York State? First, let's define impaired practice. Impaired practice is defined as, quote, diminished competence as evident in changes in work habits, job performance, appearance, or other behaviors, unquote. That comes from the ANA in 2015. It is the responsibility of nurses and nursing students to be aware and to take appropriate actions when unethical, illegal, or impaired practice or actions that place the rights or best interests of the patient in jeopardy. That also comes from the ANA in 2015. In New York State, there is the PAP, or Professional Assistance Program, or PAP. And this is a program that assists professionals who have substance use problems, but who have not harmed patients or clients. Such professionals may voluntarily surrender their license while receiving treatment rather than face charges of professional misconduct. All applications to the program are confidential. I put the link there. For further information to help yourself, a colleague, or a friend, you can phone them or write them or email them, and I put all the contact information there. There is also SPAN, the Statewide Peer Assistance for Nurses program. This is a resource for nurses coping with substance use disorder. Their assistance is provided in the areas of identification, education, and prevention. SPAN has a confidential helpline that's toll-free, and the website is there. So as I mentioned briefly earlier, there are two primary treatment approaches with respect to substance use disorder among nursing. So the first is a disciplinary approach. This usually entails due process involving a state board of nursing. If the nurse is found guilty, the license is suspended or revoked, and no state board recovery program is offered. This is historically how substance use among nurses was handled. If employment is terminated, then the nurse may no longer have health insurance or access to treatment. In cases of diversion, legal charges may be filed with loss of license and livelihood, and the nurse may be prosecuted and incarcerated, resulting in a criminal record that may forever prohibit further employment as a nurse. The less punitive and I think the more appropriate approach is the Alternative to Discipline program, which is generally administered by a third party through contractual agreements with the State Board of Nursing. The nurse refrains from practice for a designated time period while undergoing treatment, establishing sobriety and a program of recovery. Assessment may include a psychiatric evaluation. Specialized treatment often involves individual and group therapy, frequent random drug screens, mutual support group attendance. An initial return to work agreement may involve reduced hours, limited shifts, and restrictions in assignments. For example, no access to narcotics, with continued treatment and monitoring for periods of up to 3 to 5 years, and a gradual lifting of restrictions with demonstrated progress. So many, but not all, state boards of nursing offer alternative to discipline programs for nurses with substance use or mental health disorders, but there is considerable variability between states, and individual employers may or may not subscribe to these principles and practices. In addition, sanctions against nurses may be more severe than those received by other healthcare professionals. Professional monitoring programs that employ an alternative to discipline approach have been shown to be effective in the treatment of health professionals with substance use disorders and are considered a standard for recovery with high rates of completion and return to practice. In addition, alternative to discipline programs have been shown to identify and enroll more nurses with substance use disorders with potentially greater impact on protecting the public than disciplinary programs. So here's a little bit of more information about PAP, or the Professional Assistance Program. Again, I have the language that they use on their website quoted here, but unfortunately they use more stigmatizing language and haven't updated their website to reflect non-stigmatizing language. So the criteria for admission to the PAP include total abstinence from all mood-altering substances, including alcohol, temporary voluntary surrender of the professional license, participation in treatment at an agency approved by the PAP, and an agreement to be monitored by the PAP for at least 2 years after reinstatement of the license. So monitoring includes toxicology reports, worksite reports, and random observed drug screens at specified frequencies. Other conditions may apply as appropriate to the individual situation and the recommendations of the treatment provider. So the PAP governs over nurses and nurse practitioners, as well as many other licensed professionals. So when we talk about treatment programs, what are some barriers to seeking help for physicians with a substance use disorder? So this was a review of scientific papers in Medline and the Psych Info databases. They looked at studies between January 2000 and September of 2018. Their inclusion criteria included articles that focused on substance use disorder in physicians. The exclusion criteria was no mention of substance use disorder, no mention of barriers to seeking help, articles focused on burnout and work-related stress, articles focused on risk factors or treatments for SUD, and articles focused on psychiatric comorbidities, and those focused on other professionals. The results were that they saw potential barriers to seeking help that were identified for impaired physicians with substance use disorder included denial of the disease and of loss of performance, fear of stigma, psychiatric comorbidities, fear of familial, social, professional, and economic consequences, and a lack of knowledge. Their conclusions that different barriers to seeking help could be identified. Priority should be given to educating medical students to ameliorate this. Increased awareness should reduce the stigma, which even nowadays still prevents some physicians from seeking help. So unfortunately, just as we see stigma towards individuals in the general population with substance use disorder, it exists among healthcare providers as well. So this study was evaluating the efficacy of physician health programs. So this was looking at 5-year outcomes in a cohort study of physicians treated for substance use disorders in the United States. So this was a design was a 5-year longitudinal cohort study. The setting was purposive sample of 16 state PHPs in the United States. There were over 900 physician participants consecutively admitted to one of the 16 programs between September 1995 and September of 2001. The main outcome measures they looked at were completion of the program, continued alcohol and drug misuse. They assessed this with urine toxicology tests, and occupational status at 5 years. What were the results? 19.3% with known outcomes failed the program. So about 81% succeeded in the program, but about 19% failed the program. Usually the failure occurred early in treatment. Of the 80.7% who completed treatment and resumed practice under supervision and monitoring, alcohol or drug misuse was detected by urine testing in 19% of them over 5 years. 26% of those individuals had a repeat positive test result. At the 5-year follow-up, almost 79% of the physicians were licensed and working, and about 10.8% had their licenses revoked, 3.5% had retired, 3.7% had died, and 3.2% had unknown status. So what was their conclusion? About 3/4 of US physicians with substance use disorders managed in physician health programs, or PHPs, had favorable outcomes at 5 years. Such programs seem to provide an appropriate combination of treatment, support, and sanctions to manage substance use disorder among physicians effectively. This was the only study that I saw that looked at substance use and substance use disorder in physician assistants. So this was an outcome study looking at substance impaired physicians and physician assistants under contract with the North Carolina PHP for the period of 1995 to 2000. So this was a retrospective chart review looking at outcomes and see how they were common and how they differed between physicians and PAs with substance use disorder in the North Carolina PHP. So they had 233 physicians, 91% of whom had a good outcome, and good outcome is defined in the right-hand column. There's good outcome without complications and good outcome with complications, and then there's poor outcome. And only 59% of the PAs who participated in the sample had a good outcome. 15% of physicians and 37% of the PAs who participated were female and had about the same outcome. And alcohol followed by opioids was the predominant substance used by both groups. Most subjects in both groups were between the ages of 30 and 55, with the best outcome between the ages of 25 to 29, and the worst outcome in those over 55. So as I mentioned, unfortunately, there is very little data in the literature on substance use and physician assistance. So this is the only study that I was able to find. This is looking and drilling down at the data in this particular study with physicians and physician assistants. So on the left-hand side, again, you see the data broken up by male and female, MD and PA, and significantly more PAs had a poor outcome compared to physicians. Significantly more physicians had a good outcome with complications or a good outcome without complications. With respect to the breakdown by gender, 90% of female physicians had a good outcome versus 77% of PAs. 91% of male physicians had a good outcome versus 52% of male PAs. If we break it up by substance use, you can see that among those with opioids as their primary substance of choice, 90% had a good outcome. This is among physicians. If we look at alcohol, 91% had a successful outcome among physicians. If we look at polysubstance use, 86% among physicians had a good outcome. And with an other substance, which included barbiturates, benzos, cannabis, stimulants, cocaine, etc., 95% had a good outcome. If we look at the data among PAs, unfortunately, the data is not as successful as it is among physicians. Among PAs with opioid use disorder, only 58% had a successful outcome. Those with alcohol use disorder, only 46% had a successful outcome. And among those with other substance use disorder, 86% had a successful outcome. Here, if we're looking at individuals who had a comorbid mental health diagnosis, depression and bipolar, and then other, which is dysthymia, anxiety, a sexual disorder, etc., you can see that that impacted outcomes. So those that had an other mental health diagnosis, the outcomes were good, whether you were a physician or a physician assistant. With respect to bipolar disorder, physicians who had bipolar disorder and a substance use disorder, 80% still had a good outcome. However, among PAs with bipolar disorder and a substance use disorder, only 50% had good outcomes. If we look at depression, in physicians, there was still a good outcome for their SUD in 86%. However, among PAs, that success rate for depression with a comorbid SUD, only 62% had a good outcome. And then on the right-hand side is looking at that data. Again, we see that there was 100% of a good outcome for individuals 25 to 29 in both the PA and the physician subgroups. And then we saw poor outcomes in the over 55 age group for both physicians and for PAs. So what are some components of the nurse substance use disorder monitoring programs? So this analysis wanted to explore the components and requirements of state nurse monitoring programs to see what were the similarities and what were the differences between these programs in different states. So what were the methods? They used a document analysis to look at monitoring programs in various states. So they requested participation from all US boards of nursings with alternative to discipline programs, and 27 programs provided materials. So what were the results? 21 program components and requirements emerged from the review. Many program components and requirements were found in at least 50% of the program documents, including an alcohol and drug abstinence requirement was found 85% of the time. Use of mood-altering medications for psychiatric and medical conditions while participating in the program was in 70% of the programs. Use of AA, NA, or 12-step programs as an acceptable group meaning in 62%, and restricted hours and shifts with return to work in 59% of the programs. So what did they conclude? That there was wide variation in the components of a nurse SUD monitoring program across states. So they noted a lack of consistency and uniformity among nurse monitoring programs, and they felt like there needed to be more investigation to lead to what are the essential components that would lead to more positive outcomes for nurses in state SUD monitoring programs. So then they wanted to look at outcomes of SUD monitoring programs for nurses. So here they did a retrospective cohort study of over 7,700 nurses participating in SUD programs between the years 2007 and 2015. They did bivariate analyses exploring variables of successful program completion and used a forward stepwise logistic regression model to run and assess predictors of program success or failure. So what were the results? Successful program completion was correlated with the number of years of participation in the program. The highest percentage of nurses completing a program was at around the 5-year mark. Additionally, 26 random drug tests, 25 support group meetings, and 55 to 60 mutual support group meetings per year were associated with successful program completion. So what were their conclusions? Bi-monthly random drug tests, daily check-ins, and a minimum 3-year length of stay in a program were associated with successful program completion. Attending structured support group meetings and mutual support meetings was also useful. Convening an expert panel to review these results and develop formal guidelines that can be tested by boards of nursing are the recommended next steps. What can healthcare providers do for their practice or organization? So first, a quote from Stephen Ross, MD. The misuse of drugs and alcohol by physicians is compounded by their critical role as caregivers. Historically, quote, addicted, unquote, physicians either went unnoticed or were treated punitively. In 1973, the American Medical Association recommended in a landmark report entitled The Sick Physician that state medical societies establish programs to identify and treat impaired physicians. Since that time, every state had established a program or committee for that purpose. So I'm here going to present several organizations and their position or policy papers on impairment in physicians and or nurses. So first is the ACP, or American College of Physicians, a national internal medicine organization for physicians on physician impairment and rehabilitation reintegration into medical practice while ensuring patient safety. This was published in June of 2019. So what are their positions? Their positions are that the professional duties of competence and self-regulation require physicians to recognize and address physician illness and impairment. The distinction between functional impairment and potentially impairing illness should guide identification of and assistance for the impaired physician. Best practices for PHP should be developed systemically and systematically, informed by available evidence and further research. PHP should meet the goals of physician rehabilitation and reintegration in the context of established standards of ethics and with safeguards for both patient safety and physician rights. Maintenance of physician wellness with the goal of well-being must be a professional priority of the healthcare community, promoted among colleagues and learners. So this is the statement by the Committee for Physician Health, which I talked about in the prior section on how to report colleagues. So to remind you, this was established in 1974. It is a division of the Medical Society of the State of New York. It is a non-disciplinary confidential assistance program to physicians, residents, medical students, and physician assistants experiencing problems from stress and difficult adjustment to emotional, substance use, and other mental health diagnoses, including psychiatric symptoms that may arise from the result of a medical illness. They provide support and referrals to those participating in the program, but also to those calling in with concerns about physicians, including healthcare workers, coworkers, colleagues, and family members. They recommend evaluation, treatment, and or assistance to their participants and monitor their progress and recovery from substance use disorder and or mental health diagnoses. They also provide strong advocacy on behalf of the participant to continue their practice as a physician or a physician in training. They provide education to the medical community as well as other communities on recognition of stress, burnout, and illness in physicians, options for prevention or reduction of symptoms, and outreach to physician groups on their services. They try to instill hope in the lives of their clients that recognition and treatment for stress and illness is desirable, helpful, and can root the person back to optimum health as an individual and as a physician. Next is the ASAM, so that's the American Society of Addiction Medicine policy statement on physicians and other healthcare professionals with addiction. This was adopted in February of 2020. So first, they acknowledge that physicians and other healthcare professionals, like all individuals, are susceptible to developing addiction. So it also includes gambling in addition to substance use disorders. And that in some, but not all cases, that addiction may impair their ability to practice and present a risk to patient safety. The Federation of State Medical Boards, or FSMB, defines impairment as the, quote, inability of a licensee to practice medicine with reasonable skill and safety as a result of A, a mental disorder, or B, a physical illness or condition, or C, substance-related disorders, unquote. Importantly, the FSMB definition goes on to clarify that impairment is a functional classification which exists dynamically on a continuum of severity and can change over time rather than being a static phenomenon. Illness per se does not constitute impairment. When functional impairment exists, it is often the result of an illness in need of treatment. Therefore, with appropriate treatment, the issue of potential impairment may be resolved while the diagnosis of illness may remain. So depending on the stage of their illness, many healthcare professionals who develop addiction are able to function effectively, but if their illness progresses to cause impairment, there is evidence for physicians that indicates that treatment will usually result in the remission of disease and restoration of functioning, particularly with additional appropriate monitoring and continuing care. What they suggest is that the public, policymakers, regulatory agencies, and professional associations expect and deserve safe and competent care from all healthcare professionals. All parties involved should be assured that healthcare professionals with addiction have been appropriately evaluated, adequately treated, and have received or are receiving evidence-based continuing care and monitoring to ensure they are in sustained remission and unimpaired in practice. State laws and regulations vary in how they address potentially impaired healthcare professionals. Most states mandate that healthcare professionals report fellow healthcare professionals who are impaired by illness. I already discussed the New York State requirements that do mandate health professionals to report their colleagues. In some states, clinicians who have knowledge of a fellow clinician's impairment because they are treating the impaired clinician may be exempt from such reporting. Some states have statutes or rules that satisfy reporting requirements if a referral is made to the state's PHP in lieu of reporting to the regulatory agency, the licensing board, or in New York State OPMC. They have quite a few recommendations in their policy statement. So I will go through these briefly. So number one is that it is important to distinguish between impairment and the diagnosis, that the diagnosis itself does not constitute per se impairment. Number two is that everyone is best served when a competent, otherwise competent healthcare professional with a potentially impairing illness is identified early and receives appropriate treatment and monitoring. Number three, that specialized treatment programs for professionals may provide the benefit of extensive staff experience in working with this population. Treatment for healthcare professionals should be individualized to the need of that specific professional. Number four, healthcare professionals should be offered the full range of evidence-based treatments, including MOUD, medication for opioid use disorder, in whatever setting they receive treatment. Number five, a recurrence of symptoms is a recognized characteristic of addiction. Number six, diversion of controlled substances for personal use is not uncommon in healthcare professionals who develop addiction. Disciplinary responses to drug diversion should be appropriate to the harm caused by the episode of diversion. Number seven, healthcare professionals should have the same rights of privacy and confidentiality of their personal health information as other persons. Number eight, whenever possible, the reporting of healthcare professionals with potentially impairing conditions should result in efforts to restore health rather than in disciplinary action. Number nine, physicians and other healthcare professionals should not be discriminated against in the areas of professional licensure, clinical privileges, specialty certification, or inclusion in managed care or health maintenance organization provider panels solely due to their past diagnosis of addiction. Number 10, barring other substantive issues, successful completion by a healthcare professional of the requirements and associated relicensure with or without license restriction should suffice for specialty boards and professional societies to affirm certification or eligibility for recertification and or membership. Number 11, PHPs should do further studies to see if positive outcomes are replicated in more rigorous prospective studies to determine which factors are most important for producing good outcomes and whether such outcomes are sustained after PHP monitoring ends. And finally, number 12, and I'm going to read this whole one. Healthcare professionals should be educated about occupational risk factors for addiction, given healthcare professionals' unique access to controlled substances and legal authority to write prescriptions. They should also receive training in healthcare in healthy self-care and stress management practices to promote health and prevent unhealthy use of medication or drugs such as alcohol. Healthcare professionals should be able to recognize signs of addiction in colleagues and know how to help colleagues connect with non-disciplinary assistance. What does nursing say? So with respect to substance use among nurses and nursing students, this was a joint position statement of the Emergency Nurses Association and the International Nurses Society on Addictions. And this was adopted in the April-June issue of their journal in 2017. It is the position of the Emergency Nurses Association and the International Nurses Society on Addictions that healthcare facilities provide education to nurses and other employees regarding alcohol and other drug use and establish policies, procedures, and practices to promote safe, supportive, drug-free workplaces. Healthcare facilities and schools of nursing adopt alternative to discipline approaches to treating nurses and nursing students with substance use disorders with stated goals of retention, rehabilitation, and reentry into safe professional practice. Drug diversion in the context of personal use is viewed primarily as a symptom of a serious and treatable disease and not exclusively as a crime. Nurses and nursing students are aware of the risks associated with substance use, impaired practice, and drug diversion and have the responsibility and means to report suspected or actual concerns. So this was a group of nurses looking at reviews of policies and position statements. And this was looking at the group of nurses recovering from substance use disorder. So they looked at multiple, both national and international policies and position statements of nursing organizations to identify key points and to identify gaps in those policies. And these were their conclusions. The key points were that substance use disorder is considered treatable. Primary purpose of all drug and alcohol monitoring programs should be to protect the public. The public protection is achieved by providing an avenue for nurses to self-report or report a colleague in need of assistance without fear of punitive outcomes. 43 U.S. states and territories in Canada, New Zealand, and Australia have monitoring programs in place for nurses. Student nurses should be given the opportunity to have monitoring and re-enter educational programs. Hospitals and nursing schools that support monitoring and re-entry are in line with the objectives of the U.S. government document Healthy People 2020. Hospital administrators are bound to follow the ANA's Code of Ethics for Nurses, which support helping colleagues to recover from substance use disorder and return to work. Nurses who are unwilling or unable to be rehabilitated should be terminated and referred to the State Board of Nursing for license revocation. What gaps did they see? How many drug or alcohol return to use episodes are allowed before disciplinary action is taken? How can nurse executives help prevent poor patient outcomes attributed to employees with substance use disorder? How do nurse executives educate and implement intervention training with staff? How are drug screening tests used in the facility and what is the process? How is random drug and alcohol testing viewed within the organization? How are nurse executives made aware of individual nurses in recovery programs or under monitoring contracts? Are substance use problems and access to assistance discussed openly in orientation with new staff? So this came from an article looking at the impact of the COVID-19 pandemic on physicians and looking at burnout and post-traumatic stress disorder in the pandemic, where they intersect impact and interventions that can be taken. So this was looking at a systems-based approach for minimizing physician workplace stress and promoting policies that simultaneously minimize burnout and acute stress disorder and decrease the risk for subsequent development of post-traumatic stress disorder. So here were where they saw the overlap in policies to create more humane policies for decreasing morbidity in the workplace. Having meaningful work or altruism, having a psychologically and physically safe workplace, promoting humanism and diversity, and having access to mental health resources. So this same document was looking at what do we do to make our environment less traumatic for our coworkers, our colleagues, and our staff. So they identified multiple types of trauma and fatigue. So these were possible impacts that could come from doing the work that they do in the healthcare setting. So there's secondary traumatic stress. So that's experience of trauma-related symptoms in a worker as a result of witnessing the trauma or adversity of another, and that's typically quick in onset. There's vicarious trauma, the development of negative changes in worldview as a result of the cumulative impact of witnessing trauma and adversity over time. There's burnout, which includes feelings of hopelessness, fatigue, and being overwhelmed from excessive workloads and unsupportive work environments, which develops gradually over time. There's compassion fatigue. So this is experiencing a combination of secondary traumatic stress, vicarious trauma, and/or burnout. There's vicarious resilience, positive meaning making and shift of an individual's experience as a result of witnessing the resilience of others. And there's vicarious post-traumatic growth, the development of positive changes and growth in an individual's worldview as a result of witnessing others' growth after trauma. So when we think about doing our work and the experience of trauma within our work, we need to think about changing the narrative to avoid negative outcomes. So in your role, do you achieve balance between the need for flexibility and support of the workforce and the demands and needs of the organization? What are ways that we can neutralize our environment? So we want to openly acknowledge and witness the impact of the work may be having on individuals in the workspace. We want to model and utilize regulation, wellness, and self-care strategies. We want to create a setting and maintain routines that include opportunity for breaks. We need to acknowledge even small choices and options that are available for our staff members. We want to be intentional regarding noticing what's working and what's possible. And we want to continue to utilize the 5 guiding principles and values of trauma-informed care to ensure universal precautions: safety, trustworthiness, choice, collaboration, and empowerment. So part of changing that narrative is trying to build resilience and growth. On the left-hand side comes a paper and a graphic from a paper that's looking at trajectories following trauma. So we can see that an adverse event occurs. For some, it will cause impairment. For others, it will build resilience. And for others, it will build on growth from that resilience. So what do we notice now? How do we get to growth? So we witness deficiency, struggle, hopelessness, and inability, and we notice in our staff capacity, success, hope, and possibility. And those are the things we focus on to promote growth. So what can we do within our practice and organization? We can seek support from a supervisor, coworkers, and family members. We can provide support to others, but don't overdo it to the harm of yourself. We can develop informal opportunities to connect. We can utilize peer supervision or consultation teams, and we can participate in agency and community building activities. We can provide education and training on the impact of the work, self-care, wellness, and general resilience training. We can implement regular team meetings, check-ins, and debriefings that include acknowledgement of the impact of the work on us and ways to find meaning in our work. We can invite the workforce to engage with self-assessment tools, help the workforce notice what is working, how they are managing, and what positive impact they are having. We can promote a culture of wellness or self-care by messaging the expectation of it and providing time and space to engage. So we can always find 5 minutes or take 2. So, in looking at the very large topic of substance use disorder among healthcare providers, what are some of the summary thoughts that we can conclude from this, and what are some of the recommendations that we can take away? Physician impairment refers to the inability to practice according to accepted standards as a result of a medical or psychiatric issue, most prominently due to substance use and/or substance use disorder. Nurse impairment is defined as diminished competence as evident in changes in work habits, job performance, appearance, or other behaviors. At least in the United States, healthcare providers have similar rates of substance use disorder as the general population in the United States, but higher rates of prescription drug misuse. Alcohol is the most frequently misused substance among physicians treated in physician health programs. Anesthesiologists have higher reported rates of opioid misuse compared with other clinical specialties. Clinical manifestations of substance use disorder in healthcare providers are similar to those changes in the general population, however, do have some unique observations due to their profession. So these changes can include changes in mood or affect, decreased productivity, increased mistakes, inconsistent hours, complaints from patients, colleagues, or supervisors, lawsuits, evidence of diversion, and deterioration in the healthcare provider's appearance and physical health. Reports identifying physicians and nurses with an active SUD to a physician health program, an alternative to discipline program, or medical nursing boards come from many sources, including patients, families, hospital staff, coworkers, peers, and the legal system. Healthcare providers have a duty to patients and to their profession to report impaired colleagues and to assist those with active substance use disorder who are not yet impaired. In the United States, nearly all states have legal requirements that healthcare workers report impaired colleagues, and that includes New York State. Stigma towards substance use disorder, people who use drug and substances themselves contributes to the stigma towards healthcare providers with substance use or substance use disorder and their ability and willingness to seek care. Trauma due to COVID-19 has contributed to an increase in mental health symptoms, substance use, and burnout among healthcare providers. We have a responsibility to promote and support well-being, resilience, and growth. And I thank you very much for listening. And if you have any questions, you can email me at kelly.ramsey@oasas.newyork.gov. Back to Dean.
I want to thank Dr. Ramsey for joining me today. Hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including suggestions for any future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.